All right. On that note, was there anything that I said I would talk about this time that I forgot? I feel like there's something that I missed last time that I should mention. Oh, schizophrenia, in terms of how a person gets schizophrenia. So the mechanism we call fragile brain or vulnerable brain. So the idea is that a person is not born with schizophrenia, but they're born with the genetic predisposition towards schizophrenia. And then there's some sort of thing that happens somewhere along the patient's life, typically in their teenage years or early adulthood, that triggers whatever vulnerability they had so that they actually get schizophrenia. So the thing that happens, the dramatic event, is oftentimes a viral infection. So some sort of viral infection turns on or off whatever those vulnerable genes were, allowing the person to develop schizophrenia. Sometimes it is an emotional event. Sometimes it can be the loss of a loved one, maybe the parent, or it could be loss of a parent or other loved one. And it can also be a traumatic breakup with a boyfriend or girlfriend. How do you like that? Not only did you lose your boyfriend or girlfriend, but you got schizophrenia too.
How do you know if you have the gene?
How do you know if you have the gene? Well, typically they tend to run in families, but not everyone in the family gets it. So there is a genetic component to schizophrenia, but it's not necessarily genetic in the sense that you inherit it. You inherit a vulnerability toward it, and it's multifactorial, which means that there's multiple genes that are involved. It's not a single gene, yes or no, if that makes sense. We're going to talk more about genetics after we're done with neuro, so we'll do a little more detail then. I do want to mention, since I see one of you wearing your Spartan shirt, that the Spartan race dates have come out for next year. And it's going to be April 26th, which is a Sunday. It's the Sunday before final exams begin. So you should start planning for that time. As a student, you can get a $25 registration, but you have to also pay like the little service fee and whatever. So I think in the end, it turns out to be about $50 after all the fees are said and done. Do you get extra credit? No, you just get cool points. Yeah. So anyway, it's still early, so you don't have to register right now, but just think about it. And you might want to work out occasionally. But anyway, Spartan is available. I'll show you some pictures later. You're like, wow, look at that. That looks like so much fun. I wish I could have that much fun. Well, you can. Okay, so now that we're done with the psychiatric stuff, let's move on to neuro. So the very first neuro disorder, central nervous system disorder we're going to talk about is Parkinson's disease. So in Parkinson's disease, what you've got is the destruction of what are called extrapyramidal neurons. So extrapyramidal neurons, there's a portion of the central nervous system, portion of the brain that's called, I guess, the pyramid, because it looks like a little pyramid-shaped cluster of neurons. And neurons that go around that little pyramid are called extrapyramidal. So the extrapyramidal neurons that we're specifically talking about are dopamine neurons. Now, remember last time we talked about dopamine antagonists, the antipsychotics. We said that dopamine antagonists block dopamine, and dopamine is inhibitory when it comes to movement. Remember we said that, right? Said that we did. So in order to make a movement happen smoothly, you have to excite certain muscles. So if you're going to bring your hand to your mouth, you got to excite these muscles, stimulate them with acetylcholine, and then you have to inhibit these muscles, and the neurons that are responsible for that are the dopamine neurons. So in Parkinson's disease, for whatever reason, we start to destroy or kill dopamine neurons and in that extrapyramidal tract. And over time, the patient is going to develop tremor because they don't have the proper inhibitory neurons. So they'll have tremor, they'll have muscle rigidity. Does it sound familiar? Oh yeah, pseudo-Parkinsonism in antipsychotics. Huh. So you get that tremor, you get the muscle rigidity. There's also a postural instability. So they have a hard time walking, so they tend to hunch over a little bit to try, and they kind of have a shuffling gait. Also, because they don't have the ability to relax muscles as well, their faces begin to change. Now, how many of you have ever heard this from a parent? You know, you're frowning, and frowning takes more energy than smiling. Okay, fine, I'm exercising. What would happen if all the muscles in your face started to contract at the same time? Try it. Don't worry, you're not on camera. I'm on camera. Go ahead. Can't even try it, can you? Yeah. Every muscle in your face is beginning to contract, and you can't relax them. Well, that's what happens in Parkinson's towards the later into the disease, and that's called the Parkinson's mask. Because they don't have a normal expression anymore, their face is kind of fixed into this mask-like appearance. So in terms of the muscular sort of symptoms, we had tremor, we had muscle rigidity, we had postural instability, and then we had the mask. Yeah, bradykinesia means the person just doesn't move as much. And if you think about it, it makes sense because it's harder to make movements happen, so you just stop doing it. You know, like the old saying, well, if it hurts, don't do it. Well, if you have a hard time doing it, maybe you should stop doing it. And so they just begin to move less, bradykinesia. They will also typically have issues with depression. Now, there's two issues with the depression. The first one is they've got a chronic disease. That seriously impacts their quality of life. Risk for depression right there. The second is they have decreased dopamine levels in the brain. And what does dopamine help us feel? Feel good and happy and like we're doing something worthwhile. And so when you lose the dopamine, you lose some of that, and that's partly why they end up with depression. So that's kind of like the reason a person gets Parkinson's. Again, we're not sure what the precipitating problem is, but it results in the destruction of those neurons. They get those symptoms, which are known as extrapyramidal symptoms. And when you get those because of a drug, we call them extrapyramidal side effects, or EPS for short. So in the Parkinson's disease, you've got all of those muscular issues or neuromuscular issues, and then you also have the depression. So how do we treat Parkinson's disease? Oh, here's the last part. By the time we figure out that the patient's symptomatic, oh, you've got Parkinson's disease, so many neurons are gone that it's irreversible. There's no way to get those neurons back at that point that we know of with our current technology. So maybe in the future, either we'll be better at screening it so that we can figure out, hey, you're beginning to kill dopamine neurons and you're currently at 30%. So let's see if we can figure out how to stop it now. Or they might be able to say, oh, well, you've got Parkinson's, you've got 70% destruction of your dopamine neurons, but if we do this thing, maybe we can regenerate them. But right now, we don't have the ability to really do either of those things well. So once you're diagnosed, it's a permanent diagnosis, and it's going to be a continuing downhill slide. Most of the time, people who are diagnosed with Parkinson's are relatively old. Usually it's after the age of 65. However, in some people, they can be diagnosed quite young. So the poster child for young diagnosis of Parkinson's disease is Michael Keaton. I didn't say that right. Michael J. Fox. He's an actor, and his most famous role back in the 80s was, started off with a TV show called Family Ties, and then he became the guy on Back to the Future. Oh yeah, the Back to the Future guy. And now he's on a sitcom, I think Spin City. I don't know if it's still going or not. Netflix. So, it will eventually end up killing them if they don't die of something else. Yeah, eventually. So Michael J. Fox is kind of like the poster child for that because he's so famous and he was diagnosed relatively young. I want to say in his early 40s is when he got his diagnosis. So most people are looking at trying to live with this disease for 10 to 15 years, maybe 20, and they'll end up being 90. Whereas he's looking at, I've got 50 years to live with this disease as I go in this kind of downward slide. Now, one of the problems that we have is that the treatments for it can work really well at first. But as the patient continues on, the treatments are less and less effective. So over time, the patient's treatment is not going to work as well. So when you get a diagnosis at age 50 or 40, you've got a long period of time where you might not have any effective treatment at all. So it's much scarier to get this diagnosis young than it is to get it when you're older. All right, so let's go over the treatments themselves. So the problem is, in our brains, we've got a balance of dopamine and acetylcholine. So what happens in this case is we have lower levels of dopamine, but we have normal levels of acetylcholine. And it's that imbalance that's causing most of the problems. So how do you think we could fix the problem? One is we could try and increase the level of dopamine. What else could we try? We could try and lower the levels of acetylcholine. Now, do we know a drug that is used to lower the level of acetylcholine in the brain? Or at least block the effects of acetylcholine? Anticholinergics. And what's the one that's used in the brain? We learned it last time. It sounds like atropine, but it's not. Benztropine. So we can use benztropine to try and reduce the effect of acetylcholine. And that works best on the muscle rigidity. It doesn't work so well on the tremor or the mask or the bradykinesia. But it does help with the muscle rigidity quite a bit. The more effective treatments are going to be the ones that increase dopamine. So if you just give dopamine, it doesn't work out that well. Any questions about levodopa plus carbidopa? All right, the next drug class or type of drug that we have that can increase dopamine are dopamine agonists. So dopamine agonists are drugs that directly stimulate dopamine receptors. And there's 4 of them that you, I guess, can know. Some of them are older. The older drugs are derived from plants. They're called ergotamines because I know that's the structure of the chemical that they come from. So the ergotamines are older, they're cheaper, and they are less effective, and they also have more adverse effects. So a drug name there would be bromocriptine. Nowadays, pretty much there's no reason to use those anymore, unless for whatever reason you're just a special child that it works better for. More commonly, they're going to use the newer drugs that are completely synthetic. Those are more effective and they have fewer adverse effects. So the drug that you're going to learn there is cabergoline. I'm not sure if it's on your drug list, but it will be. Cabergoline. It is a non-ergot. Yeah, we're going to do this one. Yeah, there's 2 of them. This is the one we're going to switch to. I think the other one is on there now, but yeah, you can just ignore those. This is the one we're going to use. Cabergoline. Don't ask me which way it's pronounced. I say cabergoline. So for now, cabergoline. No. The 2 older drugs are ergotamines, bromocriptine and whatever the other one is. All of the newer ones are completely synthetic. They are non-ergotamines. And cabergoline is the only one you need to know. Yeah. Don't worry. When you watch this on video, you're like, oh man, I'm so annoying. He just said it, and I've got to repeat it 4 times. But it's okay. But it's okay. We understand. You know, being a nursing student is kind of like having a, psychiatric disorder. Okay. Any other questions about dopamine agonists? All right, next we have MAO inhibitors. Does it sound familiar? Now, MAO inhibitors reduce the metabolism of norepinephrine and epinephrine and dopamine. So some of them go up into the brain and work better in the brain. So they're usually called, sometimes they have like a specific subtype of dopamine receptor, and you don't need to know what it is. But the drug names that you're going to see there are most likely selegiline and rasegiline. Selegiline. Anyway. I'm pretty sure that's how you spell it. Yeah. Say it again. Right. So the thing you've got to be careful about with the MAO inhibitors, like we said before, the dietary restrictions for tyramine, no sympathomimetics, and then also you can't give them with other psychotropic drugs, especially not the SSRIs or SNRIs. So, and then 2-week washout period between them. So they're not used that often because of all those restrictions, but it is an option. All right, any questions about MAO inhibitors? Selegiline, and I want to say rasagiline, I don't know how it's pronounced.
No, that interacts with.
Oh, interacts sympathomimetics, SSRIs, SNRIs, and Wellbutrin, or bupropion. So lots of interactions, not used that often, but it is an option if the person doesn't have any need to be on those other medications. Daytime somnolence means that they're sleepy during the day. Daytime somnolence. All right. Anything else about Parkinson's that are in the notes that you have questions about? Oh, yeah, mantidine, whatever. Move along. Yep. Skip it. We already talked about anticholinergics. No, but you can look it up. Yeah. It's basically the same as selegiline, but it starts with rasa. Who cares? It's not on your test, so don't worry about it. Oh, well, why didn't you say so? Hello? Yeah. One drug is enough for now. Selegiline. Yeah. For Parkinson's. Yeah. Nardil and Marplan for depression. Yeah. Okay. Any questions about Parkinson's disease? All right, next we're going to move on. We're going to talk about Alzheimer's disease, or is seizure next in your notes? Alzheimer's. Okay, so Alzheimer's disease. By the way, there's been a move lately in some textbooks. So these are named after the doctors that first described them in patients that were published. So they're named after that doctor's name. Alzheimer's disease, Parkinson's disease. However, there's been a trend recently in some textbooks where they don't put the apostrophe S anymore. They call it Parkinson disease, Alzheimer disease, I guess as though the doctor had the disease. But so anyway, I don't know what the right way to do it is, but I'm old-fashioned, so I include the apostrophe S. Now, Alzheimer's disease, because of the name of Dr. Alzheimer, has been the subject of much confusion when I was a kid. I remember Family Ties was where I learned about this disease. There was one of Alex Keaton, Michael J. Fox's character's favorite aunts, just shows up one day. And she's like, everyone's like, oh, what are you doing here? And she's like, didn't you know I was coming? And it turns out that she forgot that she was supposed to tell them she was coming. And so she was embarrassed and blah, blah, blah. And eventually they find out that she has Alzheimer's disease. But the way they're pronouncing it so fast, I thought it was old-timers disease. So anyway, that was my introduction to Alzheimer's disease. Now, Alzheimer's disease is similar to Parkinson's in that there is a loss of neurons that you really don't have symptoms until there's a very, very significant loss later on in the disease. And by that time, it's irreversible. But this time, instead of destroying dopamine neurons, we're going to be destroying acetylcholine neurons. Now, acetylcholine is responsible for an enormous number of things in your brain. We've already talked about the role in motor movement, but acetylcholine is also essential for creating new memories. So without acetylcholine, you have reduced ability to create new memories. So you become Dory, only it's not funny. So very, very early on, there's like kind of a progression of symptoms and degrees of severity. So very, very early on, we call it mild cognitive dementia. That's kind of a stage 1. What does the word cognitive mean? Cognitive means thinking or thought. And what does dementia mean? Reduced thinking. So demented is the kind of the word there. So in mild cognitive dementia, sorry, I'm a liar. It's not dementia, it's impairment. Mild cognitive impairment is the first step in Alzheimer's dementia. So in mild cognitive impairment, the only real symptom is a decrease in the ability to make new memories. People are more forgetful. Now, some of you are going, maybe I've got that right now. No, you don't. Not in this room anyway. You know, if we had a couple people in the room who are currently in their 50s, which happens every now and then in nursing school, well, maybe you could have early Alzheimer's. The important thing, though, is this is a decrease in your baseline. So if you've been forgetful your entire life and you're still forgetful, that's not Alzheimer's. If you are getting worse in your forgetfulness, that's Alzheimer's. Does that make sense? Okay. So the very first step is that mild cognitive impairment. Now, the smarter a person is, the more likely they are to notice, but the more likely they are to be able to compensate. So they might notice that they're doing it, but they hide it from their family because they can compensate for it. Does that make sense? The best thing that can happen is as early as possible, a person gets diagnosed because you can treat earlier and you can stay functional longer and you have more time to plan what is going to happen. Because once a person has Alzheimer's, at our current level of technology, there's going to be a decline until eventually the person dies of Alzheimer's. Or they die of a heart attack or a stroke or something else first. Does that make sense? So one of the problems that we have in our culture is that we hate death and we fear death so much, we're willing to do anything to keep a patient alive a little bit longer. And all that does with Alzheimer's disease is give them more and more chance for their brain to continue to decline and function until there's a body with no person that's recognizable inside. So it's much better for families and the patient to plan how the patient wants to die rather than ending up in that state. You know, do you want the last memories of your grandmother or your own mother or your own father to be a person who doesn't recognize themselves, doesn't recognize you, can't feed themselves, can't get out of bed, skin breakdown all over the place because of that? Or would you rather your last memory of them being a conversation that you had with them about something you enjoy together? Well, if you don't have these conversations early on in the disease, you don't get to choose, and neither do they. So the most important thing we can do is recognize early, get a diagnosis early, and have a good plan of care. So we'll talk a little bit more about that as we go along. So then stage 2 and 3 of Alzheimer's, kind of like a progressive downhill slide. And so the patient is beginning to have increasing memory loss, and it's usually recent memory loss. And then eventually they stop being able to do things that they otherwise ordinarily could do. And this is especially apparent when you make them do what's called constructions. So one of the classic things you can ask them to do is to draw a clock and put the numbers in the clock. So what they'd have to do is they'd have to draw a circle and then put the numbers in the clock. Messed that one up. I can't do it. Okay. And then you put the hands at 3 o'clock. Okay. So it takes a lot of brain power to be able to do that. And this is called the clock drawing task. And if a patient can't do that, well, they probably can't drive safely either. Losing their keys is a big step. It's like taking away their freedom. So I guess it's not as big a deal in today's Uber world, but for most older people, the car is the symbol of freedom. It was when they were 15, they got to learn how to drive. When they were 16, they could go anywhere. No one could find them. This was back before cell phones. It's like, how many of you watch Stranger Things? The reason why the 80s are such a good time to put little adventures for kids is because the kid would go off into the woods and no one could find them. Now, so for most older people, that car is their symbol of independence that they've had since they were 16. And now you're going to take it away from them? Oh, no, you're not. So anyway, so they keep losing the ability to do things. And so it starts off with complicated things that they lose, and eventually it goes to more and more simple things. And eventually they can't even feed themselves. And that's typically in the most severe, which is going to be stage 4 or severe Alzheimer's disease. Now, when we deal with these patients, a lot of times they're going to become suspicious. They're not going to recognize their surroundings. They don't recognize you. You introduce yourself to them, and they're like, oh, okay, you're my nurse. And then you come back in the room 30 minutes later, and they don't know who you are. So one of the things that's really important is to explain who you are and what you're going to do. What you learned in health assessment, remember, my name is, I'm a nurse, I'm going to, that little script. You got to say that every time you come in the room. So here's an example. There was a CNA who was really good about communicating with Alzheimer's patients, but she was just having this one trouble with this one patient. Like, he would just give her trouble every time she tried to bathe him. So eventually, like, okay, what's going on here? And she'd explain what she does. She'd go in, she'd explain what she's going to do. And he's like, okay, that sounds good. He's not combative. And then she gets her supplies. She comes back in the room, gives him the bath, and he fights her the whole time. What was happening? He was forgetting who she was and what she was doing and the time it took for her to get the supplies. It's like 3 to 5 minutes, it was gone. So what she had to do was get the supplies first, then explain who she was, what she was going to do, and the trouble went away. One of the things that you'll hear a lot is, these people are stealing from me. And see, what they think, this little hospital room that they're living in, they think that's their house from 30 years ago. And they remember putting their wallet right there. But that wallet's been gone for 30 years. The painting that was supposed to be on that wall right there, it's been gone for 20 years or 40 years. And so they're looking around and they're like, I'm missing things that I should have. These people must be stealing from me. Because people are coming in and out all day long, right? And they don't remember who any of them are. So one of the things that you've got to do is kind of constantly remind them of who they are, where they are, what they're doing there.
So can they remember older memories and just not newer ones?
Usually they can recall older memories until fairly late. Yeah, so they'll begin to lose older memories as they get into this stage. And then in stage 4, they also begin to lose those early memories as well. Underlying personalities tend to come out because they lose their inhibitions. So old people are kind of like young people and drunk people. So what happens with Alzheimer's is that if they were kind of a mean person, but they're held in check by common courtesy and manners, those go away and there's a mean person left underneath. If they're a really nice person, that kind of gets they become nicer as they go along. One of the things that you want to do is you want to talk with the family members about what the person was like before they had Alzheimer's. And you try and want to work with them to get their environment in a way that is helpful for that. So let's say that you have a patient who is a neat freak and they love to organize things. Well, you can give them a job of organizing a drawer, and they'll be, maybe an hour or two of fixing the drawer. And then you know what you do when they go to sleep? Mess it up. And then they get to organize it again. And so they feel like they're being productive and useful, and they don't realize that they are doing the same thing every day. If they're living at home, you want to involve them in the work of the house. Like with little kids, so like little kids need a job, because if they don't have a job, they're just going around crazy. By giving them a job, it makes them feel responsible and part of the family. So your job is to set the table. Well, you need to do the same thing with your elderly Alzheimer's parents. Give them a job, and it should be something that they can handle. So, if they can set the table, let them set the table. If they drop the dishes, well, get some dishes that don't break when they drop. Common sense things that a lot of people are like, oh, I never thought of that. If the person loved to fish their whole lives, then it would be helpful to have maybe fishing shows that they can watch. So part of the person who was there is still there, and you have to work with the family to figure out who they were and what they did and what they enjoyed, so that you can try and tailor their environment in such a way that they will have an enjoyable life while they're in your care. So sometimes they're only there for a couple days because they got pneumonia. Other times you're working in a nursing home and they're going to be there for the rest of their lives. You need to work with that family to make their lives as meaningful as possible during the time you've got them. Let's see what else. The planning part. At the moment, the plan of care for an Alzheimer's patient is keep them alive long enough so they can die of something else. And really, unfortunately, that's the plan of care. The problem is we're better at preventing death from heart attack and pneumonia than we are at slowing down the slide of Alzheimer's, which is why it's so very important to involve the family and the patient in their plan before they get to the point of not being able to make decisions for themselves anymore. There's a nurse in this county, and she's also an attorney. She does estate planning, and she specializes in this sort of thing, like planning for the care of people who have Alzheimer's and that sort of thing. And she was giving a talk once to some community group, and at the end of it, someone came up and said, "My mother had Alzheimer's. My last memory of her was anytime I came in the room, she would cuss and yell and scream and hurl feces at me. She would eat her own feces if she wasn't throwing them at me. If I ever get diagnosed with Alzheimer's, I will shoot myself that day." The reason her mom was in that situation is a failure to have communication with the healthcare providers at the appropriate time. We are so much better at preserving life, body, than we are at treating Alzheimer's, that you just can't hope they know the right thing. One of my favorite articles is called How Doctors Die, and it has nothing to do with Alzheimer's per se, but more so in the sense of terminal illnesses in general. When doctors get terminal illnesses, they tend to unplug, spend life with their family, enjoy their last couple months, and then die. Meanwhile, what they're recommending to their patients are these horrific treatments that are incredibly costly, and the patient sometimes only lives a few months longer, or it destroys their quality of life for several years, and it destroys their family inheritance. And so they're talking about the difference. Why is that difference? And it boils down to doctors are not very good about talking with patients what it means in terms of when you say you want this. So like if a doctor comes to a family member and says, "Would you like us to do everything?" What do you think the family member is probably going to say? Yes. And what is the family member thinking? Everything reasonable. You're going to do everything you should do. They're not thinking literally everything. But when the doctor's asking the question, what is he meaning? Literally everything. So if you have like a 98-year-old woman who comes in with chest pain, And they're like, yeah, we want you to do everything. Take good care of her. They don't necessarily mean we want you to crack open their chest and, break all their ribs trying to bring them back a third time after they've coded 3 times. But that's what the doctor is actually saying when he says, do you want us to do everything? And so it's that lack of communication and misunderstanding on both the parts of the public and the healthcare providers. That's what causes that disconnect. So you as nurses have an incredibly important role to play in helping that conversation to take place appropriately. Does that make sense? All right.
Socialization helps keep
Okay.
like is there if you have like would it be better to put a patient with Alzheimer's in a nursing home where they could have community or like have a sole caregiver?
It is generally best to keep the patient in as familiar surroundings as possible for as long as possible, but also socialize them. The problem is if you're going to work, let's say you've got your mom at your house and you're going to work, they're by themselves most of the day. Now, eventually there comes a point where they can't be by themselves anymore. Now you have to hire a person, but they're still only having interaction with one person or no persons for a long period of time. So there's beginning to grow up what they call like Alzheimer's care places. It's kind of like daycare for Alzheimer's patients. So we have one of those organizations here in Palm Beach County. It's called Alzheimer's Community Care or AlzCare. And you guys will actually get the opportunity to go there in fundamentals and then also in community nursing so you can see kind of what that's like. But generally you want to give them as meaningful a life as possible. So that's going to include as much social interaction as possible. Now, social interaction will not slow the decline, but it'll make their life more meaningful where it is. Doing mental mental exercises does not slow down Alzheimer's disease. So, by the way, it also doesn't raise your IQ. We'll get there. So those little apps, you like raise your IQ. It does not raise your IQ. You know what it does? It makes you better at whatever that little thing is. So you can get better at whatever that little game is, but it's not increasing your overall intelligence. But, if you want to get good at math, what do? Math problems. You got to practice them. So it can help specific skills, and if those skills are something you want to be good at, well, then do those little apps. But the only thing that has really been shown to slow down the progression of Alzheimer's disease is exercise. The only thing. And it doesn't matter whether it's cardio or whether it's resistance exercise. That's the only thing. Now, later on in the course, I'll make a case why resistance exercise should be the default. You should do both, but if you have to choose one, it should be resistance exercise. Well, like weights. Weights or resistance, but something that is challenging to muscles. All right. Anything else about Alzheimer's? Any questions about the disease before we move on to drugs? Oh, yeah. So morphology of the disease itself. The genesis of what happens. So here's a neuron inside the brain, and here's a little protein, and it gets broken. It's supposed to break off like right there, and then this little piece gets recycled. But what happens is it breaks off there. And so you've got this little fragment of protein that you have no enzyme to break down. So these are called tau proteins. So these tau proteins accumulate in the brain, forming what are called neurofibrillary tangles. And then that causes an inflammatory reaction, which leads to the deposition of a starch-like plaque called amyloid plaques. Now, in the old days, the only way to diagnose a patient with Alzheimer's disease was wait till they died, cut open their skull, and see if they had those two things, neurofibrillary tangles and amyloid plaques. You can diagnose Alzheimer's nowadays with modern imaging before the patient is dead. So if you ever hear someone say the only way to know, that's like 20 years out of date, maybe 30 years out of date. Now, 20 years ago, I heard a neurologist say, we're doing all this, we discovered this little thing right here, and we are confident that we will be able to, reverse Alzheimer's disease and prevent it 20 years later, we have drugs that can dissolve plaques and fibrillary tangles, but they don't actually make the Alzheimer's better. So we are way ahead of where we were 20 years ago in understanding the disease, but our treatments are still not as effective as they could be. One thing we also have to be careful about is make sure there's a good diagnosis. So you want your patient to see a specialist because there are multiple forms of dementia. And if you get a diagnosis of Alzheimer's when you actually have something else, the treatment is not going to be as effective. So we'll talk about those something else's after we talk about the treatment for Alzheimer's. So for Alzheimer's, the first treatment that we have is cholinesterase inhibitors. Do you remember what cholinesterase is? From Pathopharm 1? Breaks down what? Acetylcholine. So the problem with this patient is they don't have enough acetylcholine, right? So by giving them more acetylcholine, well, by preventing the breakdown of acetylcholine, they've got more in their brain. So that's going to improve their ability to think and to form new memories. The cholinesterase inhibitor that we are going to learn is called diazoxide or Aricept. There are two others. You can look at them, but this is the one that's going to be on your test. Actually, you know what? The others might be on your test too. Yeah, if it's on your list, it could possibly be on your test. Say it again. Yeah, did I do it wrong? Yeah. Donepezil. Like that? Who cares? It's on your list. I only write out Aricept. But anyway, so you get the idea. So the other one is like Razidine and galantamide, yeah. One of them had to be renamed because it was too similar to something else. So it's like, I learned the old drug and now I can't remember the new drug because I have Alzheimer's. Anyway, the important thing is if you ever see a patient on one of these drugs, you know what they're being treated for. What are they being treated for? Alzheimer's disease. So these drugs are indicated for mild to moderate, which is going to be this like stage 2, stage 3. As far as adverse effects, what do you know about higher levels of acetylcholine? What does it do in the body, in the peripheral nervous system? I wonder what it could do. Increases peristalsis, increases secretions of the eyes, nose, and mouth, causes lower heart rate, causes increased urination. So the number one adverse effect is actually going to be GI because you're giving an oral drug, so it's acting locally in the GI tract. So diarrhea and abdominal cramping, nausea, that is actually the number one adverse effect for all of the drugs. Now, one of the interesting things about these drugs, and I don't know to what extent this is really true in terms of research, but it was what we were taught, is that if you take a look at a patient's mental function who's got Alzheimer's, they're kind of going this downward trend. Then you put them on the drug and they actually get better, but they continue on the trend. So what a family member says is, hey, that drug worked. And now they say, hey, that drug isn't working anymore. So the idea is, well, okay, well, if it's not working anymore, why don't we take them off the drug? So if you take them off the drug, sometimes the patient will drop back down to there. Oh, it was working. Crap. Let's put them back on the drug. But you can't get them back up. Now, I don't know if that was just a marketing story that was told to us by companies that wanted patients to stay on their drug, but that's the story we were told. Does that make sense? Okay. So it's kind of like, if it ever worked, keep them on it, because if you take them off it, you might not ever be able to get them back to where they were. The next drug that we have is called memantine, or Namenda. Now, this is an interesting drug because I feel like whoever named this drug got it backwards on the FDA application, They meant to call it Namenda, and they meant for the brand name to be memantine. Because wouldn't you rather take memantine that helps your memory than Namenda? Which who the heck knows what a Namenda does? As it turns out, Namenda affects NMDA receptors. That's where the name Namenda comes from. So at the NMDA receptor, so here's a cell body, and here's a dendrite. Now, the way that your brain processes should this neuron fire or not. Do you remember the whole aspect of how we get a neuron transmission in the first place? What's it called? What's a neuron transmission called? An action potential. And what causes that action potential? How is this signal sent in the first place? What is the signal? Is it chemical? Is it electrical? Is it physical? It's an electrical signal. And what causes that electrical signal? Cool cats and nerds. Sodium and potassium. So you've got the sodium on the outside, potassium on the inside. Sodium channels open up, allows the sodium come inside, and as that sweeps down the neuron, you get what's the fancy word? What? Depolarization. You see that knowledge is still in your head somewhere. Just wasn't, where it could access it. Yeah. So the way that we send the signal is to depolarize the neuron. Now that depolarization actually occurs up here in the dendrites and cell body. So you've got thousands of connections with different dendrites, and every single one of those is coupled to a receptor. And when that receptor is activated, one of two things will happen. Either something will come in, which is that something is probably calcium or sodium, and the more sodium and the more calcium that come in, the more positive the inside of the cell becomes. Or it will reduce the ability for calcium or sodium to get in. It'll either increase it or it'll block it. Does that make sense? So the more positive the cell becomes, the more likely it is to depolarize. So it's got hundreds of little synapses all over, thousands of little synapses that are saying, become less stable, become more stable. Become less stable, become more stable. When there's enough become less stable signals, eventually the whole thing goes. Does that make sense? Now, one of the neurotransmitters that's involved in this whole thing occurs at NMDA receptors. And the neurotransmitter is glutamine. Glutamine is coupled to calcium channels. So when you have glutamine binding to an NMDA receptor, it lets calcium go in. Now the problem is, in Alzheimer's disease, is that you have these neurofibrillary tangles that kind of tangle up the glutamine and allow it to bind longer than usual. So you get too much calcium coming in. Now imagine for a moment that you're trying to do something. Maybe you're trying to insert an IV. How many of you think you might be able to insert an IV one day? Concentrate, really. Now imagine someone screaming in your ear, "You're doing it wrong, you're gonna kill him, oh my gosh, what's going on? Are you sure that's the right thing to do? Are you using the right thing? Is that the right needle? Maybe it should be a different size. How do you know it's the right one?" And they just yell it at you. And then you got someone else yelling, "You're doing great, keep going." "No, not that way." Do you think you'd be able to do it very well? Okay, so what happens is with all of this excess glutamate stimulation, with all the excess calcium coming in, it makes it harder for the real signals to come through. So what this drug does is it blocks that receptor. So the glutamine isn't allowed to sit on it as long. And supposedly, the way that it works is it just kind of quiets down the excess noise, which allows a person to think better. Memantine is the only drug that is indicated for moderate to severe Alzheimer's disease. Now, how effective is it? I have no idea, but that's how it's supposed to work. Oh, by the way, glutamine is broken down by enzymes on microglial cells. Do you remember what a microglial cell is? So here's your little microglial cell. It's a macrophage that lives inside the central nervous system. So the enzyme is there, but these neurofibrillary tangles are kind of blocking the glutamate from getting to that enzyme where it's going to be broken down. That was fun. All right. We're going to talk about the things that can look like Alzheimer's, other forms of dementia, and then we're going to take a quick little break, and then we'll come back with seizures. So the first thing is there's multiple causes of dementia. And the number one cause of dementia is Alzheimer's disease. But there are a few others. So Alzheimer's is number one. And then we used to say that number two was vascular dementia, which is basically caused by chronic arterial disease. As you get buildup of atherosclerotic plaques in your brain, it just reduces the blood flow to the brain. And by doing that, reduces your brain's ability to function. So the way that you would treat that is you would treat the patient for atherosclerosis, kind of like you would treat them for heart disease or stroke. And a lot of times their perfusion will improve and their symptoms will improve. So originally we said about 70% of Alzheimer's was, or 70% of dementia was Alzheimer's, and then about 25 to 30% was vascular dementia, and then the remaining was other, and the one that everyone's really afraid of there is brain tumor. Why are people so afraid of brain tumor? And by people, I mean healthcare providers. Because if a patient comes in and you assume it's Alzheimer's or vascular dementia, and it turns out that they had a brain tumor you missed, you're getting sued. Oops, no one wants to miss brain tumors. The problem is screening for brain tumors is kind of expensive. Of course, nowadays with the improved imaging we have that can diagnose Alzheimer's ahead of time, it actually works out in our best interest because we can look for both Alzheimer's and brain tumors at the same time. So you're no longer just looking for brain tumors. The other issue is we can distinguish between what we thought was Alzheimer's and a missing thing in the middle here. And that missing thing is called Lewy body disease. So Lewy bodies were discovered by Dr. Lewy, and they're little particles, bodies, that live in, or that not live, but are inside of central nervous neurons. So the accumulation of Lewy bodies, where does it occur? Inside the neuron. And that accumulation of Lewy bodies impairs their ability to work correctly. Lewy body disease is treated differently than Alzheimer's. So the important thing is that we don't just assume that the patient has Alzheimer's. We want to check to see if it's Alzheimer's versus Lewy body disease, so we can get them appropriate treatment. The treatment for Lewy body disease outside the scope of this particular course, so you don't have to memorize that. But some of the characteristics that might help you go, could this be Lewy body disease and not Alzheimer's? Is that patients with Lewy body disease will often have Parkinson's syndrome along with their Alzheimer's symptoms. So it looks like a combination of Alzheimer's and Parkinson's disease. The other thing is that patients who have Lewy body disease are more likely to confuse family members. So they see you and they think it's their sister or their wife. Now, if you're the daughter of someone, so if you're a girl, do you have a resemblance to your mother? Maybe not perfect, but you look a little bit like her sometimes, usually. So, and a lot of times you look like a younger version of her. So when the person with Alzheimer's, your dad, sees you, he mistakes you for his wife. Does that make sense? That would be much more common in Lewy body disease than with Alzheimer's disease. All right, now I tell a story about Alzheimer's symptoms in terms of what patients are kind of like sometimes as they get older. So since we're recording, I should mention it. My wife's grandmother, she lived to be, I think, 101 before she died. And she was living with her oldest daughter, and her oldest daughter is, in her 60s at the time. So, she the mother was in her 90s, the grandmother was in her 90s, the aunt, my wife's aunt, the grandmother's daughter was in her 60s. So they were sleeping in the same bed because that was easier to be able to take care of her. Just sleep in the same king bed together. And one morning, grandmother's trying to wake her up. Get up, it's time to go to school. It's not time to go to school. Yes, it is. You're going to go to school. You're going to be late. I don't go to school. I'm 60 years old. You are? And you're 98. I am? So she was reliving a day that had occurred 50 years earlier. In her head at that moment in time, her daughter was 10, 12 years old, and she was, 30s or 40s. So that sort of thing can happen quite often in Alzheimer's disease. And then as a person gets older, those sorts of things begin to go away even more. Now, how many of you have seen The Notebook? We have to address The Notebook. All right. So the movie The Notebook is an utter Hollywood cop-out. Because in the movie, and this often happens, where, a lot of the time you're talking to someone who's not your old mother or, your old father anymore. It's this new person who doesn't remember things. And then all of a sudden you're talking to the person you knew, and they're there, and it's amazing, and then they're gone again. Sometimes it's a couple minutes, sometimes it's a couple hours, but that sometimes happens. So in the movie, she doesn't remember who he is. He's reading the book of the story of their lives together, and then she remembers who he is. And then they hold hands, and they go to sleep, and they never wake up together again. And it's so romantic to die together. But in the book is much more realistic. So in the book, they drift off to sleep, and the next morning she wakes up screaming because there's a stranger in her bed. That's what really happens. So anyway, I didn't like the book either, but at least it was more true to life. Hollywood ending.
So what is an example of something for the Lewy body?
Say again?
So you said for the Lewy body disease, so it would be like an example.
An example. So the two main things you're looking for with Lewy body is, number one, there's mixed with the Parkinson symptoms, and the second is more likely to mistake family members. Those the two kind of symptoms that we're talking about. No, just right, mom for daughter, brother for sister, brother for husband or whatever it is. Yeah. All right. Any questions about Alzheimer's? Yeah. We just mentioned dementia. We went through all the dementias. So vascular, you treat atherosclerosis. Brain tumor, well, you got to diagnose it so you can treat it. I don't have any drugs for these things. We will talk more about how you treat atherosclerosis when we talk about cardiovascular diseases. So at that time, everything that applies to that would apply to here. Oh, drugs can cause, drug-induced dementia. That is usually because of anticholinergic adverse effects. So back in Pathopharm 1, we mentioned that anticholinergic effects can cause mad as a hatter. So it can cause dementia, and it can look just like Alzheimer's disease. So anytime you have a patient who's got dementia, the first thing you want to do is do a good drug history, and as much as possible, eliminate drugs that have anticholinergic adverse effects. So grandma is having some incontinence, so they go on tolterodine. Detrol helps their incontinence, but now they can't remember who they are, or they start forgetting things they weren't forgetting before. Take them off the drug and see what happens. So that should always be the first step anytime you've got a patient with dementia. And then, get the good screening. All right, any other questions about Alzheimer's disease? By the way, you should know your anticholinergic drugs. They might happen to be on this test. In that specific situation, no less. What? Atropine. Hypertropium. Oxybutynin, tolterodine, dicyclamine. Yeah. Now, also, I've given you a long list of other drugs that have anticholinergic adverse effects. So more than just the anticholinergics have anticholinergic adverse effects. One of the most common is, of course, Benadryl diphenhydramine. But anyway, you can look over that list on your own time. Any other questions? It should be in your notes. If it's not, remind me, send me an email and I'll put it there, or just send it to you separately. All right, let's take a quick break and we'll come back and talk about seizures. All right, let's talk about seizures. So the next disease is going to be epilepsy, which is a disease of having seizures. So first of all, we have to define what a seizure is. And a seizure is coordinated, inappropriate neural activity. Now, the example that I like to give is doing the wave at a sporting event. So how many of you like to try and get the wave started? Anyone? No. But if the wave happens, you'll participate? All right, so here's the way that a wave starts. Hey, let's do the wave, everybody. Come on, let's do the wave. Come on. Come on, do it, come on. And if you can get it, and then like 3 or 4 people, like, and it goes for like 10 feet and then it stops, right? But if you can get enough people recruited at once, all doing it, then eventually it can go around the entire stadium, sometimes multiple times, right? So the person or group of people that are trying to start the wave are called the focus. Now, in seizure lingo, we call it the irritable focus. Neurons should only fire when it's appropriate. And how do we know it's appropriate for a neuron to fire? We just talked about it when we talked about Dementia. So when there's enough sodium channels and calcium channels that are open, that allows it to cross below a certain amount of positive charge threshold, at that moment, then you get depolarization, you send a signal. But what happens if a neuron is irritable and it just starts sending out messages for no reason? Now, a single neuron doing that, is that going to cause a problem? No, not really. But by sending out inappropriate signals constantly, it can recruit nearby neurons to start doing the same thing. Come on, everybody, let's go. So the first step is we have that irritable focus, which is either a single neuron or a little group of neurons that begin to fire inappropriately. What they want to do is they want to get nearby neurons to do the same thing, and that's called recruitment. And if you can get enough neurons that are recruited, you can eventually cause a seizure. Now, seizures come in 2 main flavors: generalized and localized, or focal. So with a generalized seizure, the key is that the entire brain is involved, or most of the brain anyway. With a focal seizure, only a certain part of the brain is involved. So with generalized seizures, the characteristic feature of them is loss of consciousness. And there's 5 major types of seizures that we need to talk about in this generalized thing. The first one is probably something you've heard of before, and it used to be called grand mal seizures. How many have ever heard that term before? Okay, so when we think of a seizure, what we typically think of is grand mal seizures, which is French for the big bad. Nowadays, we classify it as tonic-clonic. It's helpful to know both. but on your test, grand mal will not show up most likely. So a tonic-clonic seizure. So what does tonic refer to? I mean, it ends in IC, so chances are it's an adjective. What's it describing? Yeah. So what if we took the IC at the end and we put an E instead? Tone. What kind of tone? Muscle tone. So think of every muscle in your body suddenly spasming out at the same time. Typically, patients will do like this. It's kind of like an arch. Now, I can hold this because I'm trying to, but what will they most likely do? Fall. So during the tonic phase, patients usually fall on the ground. Then, after the tonic phase is over, which can last anywhere from a couple seconds to like 30 seconds, they begin to shake uncontrollably. The muscle spasm is rigid. The shaking is clonus. So clonic describes clonus. So tonic-clonic seizures, muscle tone, patient has muscle spasm, usually falls, and then that's followed by uncontrollable shaking, clonus. So that's the tonic-clonic seizure, formerly known as grand mal seizures. The next one is called absence seizure. And this used to be known as petit mal, which is French for the little bad. Now, absence seizures is, we pronounce it like it's French. So, in French, en is pronounced en, not n. So they're not French fries, they're French fries. And if you've ever seen Better Off Dead, have you ever seen Better Off Dead? You don't even know what that movie is, do you? Do you know who John Cusack is? Oh, man, getting old. Well, he was an actor. Back in the day, he was in a whole bunch of like teen and early young adult comedies. And one of those was called Better Off Dead. So in Better Off Dead, his mother's crazy, but there's a French exchange student who lives next door, and they have her over for dinner. And so she's like, everything is French. French fries, French dressing. So anyway. There you go. So absence, I'm probably mispronouncing it, but it's not absence seizures, it's absence seizures. Got it? If you call them absence seizures, no one's going to know what you're talking about. You can pronounce it that way in your brain, but they are called absence seizures. I'm not lying to you. I'm not playing you.
I've heard it called absence.
Yeah, but only by people who don't know better. Yeah. So, in absence seizures, it's like the lights are on, but no one's home. So it's like the person is absent from the body. And absence seizures can last from anywhere from a few seconds to a couple minutes. They're most common in children. Right, when they're having hundreds of seizures a day, it could be absence seizures, but it's most likely partial seizures. Because partial seizures can mimic absence seizures. It's non-generalized. Yeah, I was saying localized, but the correct term is partial. It just came to me in a dream. All right, so absence seizures, and then we have what's called atonic seizures. So that is a sudden loss of muscle tone. And sometimes these are called head drop seizures, because if you lose muscle tone in your body, so it's kind of like when you guys are falling asleep in class, and you're like, you guys don't think we can see you up here, and you're like, oh, yeah. No, that's what happens when you're falling asleep. In the seizure, you don't have that control because you're not waking yourself up. Yeah. Yeah. So if a person is standing up, they could fall. But if they're sitting down, you don't really notice. Just and that can last for a couple seconds to however long. And then the last one is myoclonic seizures. I know I said 5, but hold on a second. So myoclonic. So these are similar to tonic-clonic, except that there's no tonic phase. The patient just has muscle shaking. So myomuscle clonic shaking. The fifth one, which is not related to the rest, are called febrile seizures. In febrile seizures, they are caused by fever. And what makes these different than the others is that it's not actually epilepsy. It's not a disease that's going to continue with the person. Having a seizure from fever does not give a person epilepsy. It's associated with the fever, and when the fever comes down, the risk of the seizure goes away. Does that make sense? Okay, now, there are other reasons besides epilepsy and fevers why a person can have seizures. So some examples of those are electrolyte imbalance. Which one in particular do we talk about that causes seizures? Seizure, coma, death. Oh, sodium. Yeah. So sodium is too high, sodium is too low. Both of those can result in seizures. Other electrolyte imbalances can also cause seizures, but sodium's like the big one. Certain drugs can increase the seizure risk. We've already learned one of those this semester. What is it? Bupropion, Wellbutrin. And what do we do to try and reduce the risk of seizures in patients who get that? We don't give it to kids, anyone under 18. So there are reasons why a person can have seizures other than, we don't know, you just got them, you're special. But when people have continued seizures without a particularly identifiable cause, then that's going to be epilepsy. We'll get there. Yeah. So now we have partial seizures where the entire brain is not involved, only part of the brain is involved. And the symptoms of these can vary depending on the type of seizure not the type, but what part of the brain is being affected. So if the part of the brain that is being affected is the part that's responsible for sight, what's the person going to experience? Weird visual things. If it's the part that affects hearing, what are they going to do? They're going to hear weird things. So if it's the part that does coordination, they're going to lose coordination. So the symptoms of a partial seizure depend on what part of the brain is affected. Now, there are typically 3 stages to a seizure. The first one, and this one doesn't always occur, but it's called, let me get rid of the partial so you don't think that this is underneath partial. No. Yeah. Outside of scope. It's just there. Okay, so the 3 stages. The first stage is called aura. And not all seizures have aura. But an aura is symptoms that occur before the seizure happens. Sometimes it happens just a couple minutes before. Sometimes it will happen a couple days before. So anywhere from a couple days to a minute or less. They're usually sensory disturbances. So a person will begin to get they'll hear weird things, or they'll see weird things, or they'll have a tingling in their skin. And so what's happening is that neural activity is making them experience things that aren't actually there. Now, some patients love their auras, and some people, it freaks them out. Yeah. So as an example, Dostoevsky, the guy who's the author, wrote, not War and Peace, he wrote Crime and Punishment, the brothers Karamazov. So that guy, he had epilepsy, and he would say that right before he had a seizure, it felt as though the world was unfolding in front of him, and he was about to learn the secret to everything. And just before we learn the secret, seizure happens. So he actually enjoyed his his feeling, his aura. There's another guy who he said that he would have this kind of like sense that a seizure is about to happen, and if he turned one direction, the seizure would happen, and if he didn't, then the seizure wouldn't happen. Yeah, that's what he says. So seizures are weird, and the auras can be even weirder. Then we have the seizure itself. And then after the seizure is called the post-ictal state. Don't ask me what ictal means. No idea. So in the post-ictal state, patients are usually confused. They're often very tired, and they might have some muscle pain because of all of the muscular stimulation that's been happening. Seizures are incredibly demanding on your body. You know, you're using an enormous amount of brain power. The temperature inside your brain is going up. And you're a lot of times using a lot of muscle power as well. So when you come out of it, a lot of times patients are also can be hypoglycemic. So you want to check their blood sugar. And you may need to give them some food or something to eat so that they can recover from that post-ictal state. Now, if you've got a patient with seizures that you know is at risk for seizures, you typically are going to implement seizure precautions. And you guys are going to learn that in tech skills and fundamentals. So I'm not really going to go into detail about what that is. But the important thing is you should be ready for a seizure. And what do we call being ready for a seizure? Seizure precautions. So for now, just say seizure precautions. Now, if a patient is at risk for seizures, sometimes they will have a drug order. If the patient has a seizure, you give them this drug. And the most common drug to give for seizures, mid-seizure to stop the seizure, is going to be benzodiazepines. And which two in particular? Ativan, lorazepam or diazepam Valium. Even if they don't have an order for stopping the seizure, if the seizure goes on for longer than 15 minutes, now the patient's considered to be in status epilepticus, and they're at risk for permanent brain damage. Oh, whatever it says in the book. Yeah, when you read about status epilepticus, some sources say like 15, some say 20, and some say 30, so go with whatever it says in your book. But the treatment of choice for status epilepticus is benzodiazepines. So ideally, the patient already has an IV, because that way you don't have to try and be sticking them with the needle while they're having their seizure. If your benzodiazepine does not bring the patient out of the seizure, then the next step would be to put them in a barbiturate coma. Well, you could try barbiturates first. If the barbiturates themselves, it stops, but then they start again, then you put them in the barbiturate coma for 3 weeks, and then you bring them out, see if they stop having seizures. That's a long time. So the risk, what's the main risk of extended seizures? Brain damage. And what causes the brain damage? Causing increased temperature in the brain. Increased risk of brain injury from increased temperature, from all the neural activity. Now, we think of epilepsy as a kid's disease, but it's not always a kid's disease. And kids grow up, and they don't always grow out of having seizures. So there are actually more adults who have seizures than kids, even though it's more common for kids to be diagnosed. Does that make sense? The way that we diagnose seizure disorder is by checking brainwave activity. And what tests would do that? An EEG, which stands for electroencephalogram. When you've got a kid who's getting EEG testing, it's kind of a boring day for them because they got to sit in a room relatively stimulus-free, because certain stimuli can cause seizures. So you want to, and it can also interrupt the test because, like, is the kid having brain activity because they're interested in stuff, or are they having brain activity because they're having a seizure? So it's a very boring, long day for that poor kid. And it's kind of uncomfortable because they've got, electrodes in their hair, stuck to their hair, trying to get down onto the scalp. Because you don't measure brain activity by sticking the electrode to their hair, right? You got to like separate the hair out so that you can stick it on their scalp. But anyway, so that's how we do it, is electroencephalogram. And then the number one thing we've got to do for patients who are having seizures is medications. The number one cause of having seizures, the number one identifiable cause of having seizures is undertreatment. About half of all seizures could be prevented if patients took their medications. But who wants to have those stupid medications? I mean, I only have like one seizure a year anyway. What's the potential danger of having a seizure? Well, you could hurt yourself. You could fall, crack your head open. What if you're driving? Well, you could crash into someone else, kill them too. What if you're swimming? Might drown. So patients who have epilepsy, if they typically are not allowed to drive unless they've been seizure-free for at least 2 years, and they're never supposed to swim by themselves. So if you're a kid who's got epilepsy, it's like you don't necessarily get to drive when all the other cool kids get to drive. But in today's Uber culture, it's not as big a deal as it used to be. Okay, so as far as drugs go, there's 3 main types of drugs or mechanisms of action. The first one is drugs that block sodium channels. So remember, way back through the mists of time, what is it that causes a neuron to transmit a signal in the first place? Sodium what? Well, and sodium-potassium pump sets up the resting potential, but then what has to happen? Sodium channels open, allows sodium to come inside. So if we inhibit sodium channels, it will slow down the transmission of a neuron. Now, if you completely block the sodium channels, what happens? You completely inhibit, you block the nerve. So that's actually how drugs like lidocaine work. They inhibit sodium channels, and that reduces our ability to feel pain, but it'll also reduce our ability to move as well, right? My favorite. Maybe. How many of you have experienced that at the dentist sometime? Okay, so the problem with giving, now that's acting peripherally. Now we're going to give a drug that affects central nervous system sodium channels. The big thing that's going to happen as an adverse effect is you suppress the whole system. And now what happens to our patient? Yeah, it depresses their level of consciousness and they go unconscious or go to sleep. So you need a drug that can inhibit the sodium channels enough that you suppress seizures, but not so much that you make them go to sleep. And the very first drug that ever did that was called phenytoin. So phenytoin is also known as Dilantin, and even though it's a really old drug and it's not used that much anymore, there's a lot of patients who were started on it 30 or 40 years ago, and well, why mess with success? Let's not take them off the old drug and put them on a new drug when that might cause a seizure. They've been seizure-free for 30 years. Let's just leave them alone. So you'll still see patients on some of these older drugs, even though they're not that commonly prescribed for new patients. So phenytoin or Dilantin was the very first one, and it has a little characteristic that makes it dangerous. And that characteristic is called exponential dosing kinetics. Now, most drugs, when you increase the dose, it goes up like this. So kind of like a flat S, right? Right, if you squint, turn sideways. Okay. So in this part right here, it's pretty straight curve. It's kind of linear. that make sense? So this is the normal dosing expectation. As you increase the dose, you get a little bit more response until it begins to flatten out. Now, the slope of this curve might be really steep or it might be really shallow, but it's more or less a straight line. What happens in exponential kinetics is that you give a higher dose and you don't get very much anything. And you give a higher dose and you don't get much of anything. And you give a higher dose and then all of a sudden it goes way, way up like this. So here, if you double the dose, you more or less get double the effect. Here, you double the dose and you get nothing. You double the dose again, you get nothing. You double the dose again and, oh, toxic. So this right here, this exponential is what makes the drug so dangerous. There's also quite a bit of variability from person to person, and even within inside a person, there's also variability. So what does that mean when there's a lot of variability like that? What do we have to do? We have to check drug levels. So you're going to have to draw peak and trough levels occasionally on the drug. So that's the main issue with the drug, is that you've got that exponential kinetics, which makes it dangerous. The next issue with the drug is that there are some nasty side effects. In particular, if you give the drug IV, it can cause cardiac dysrhythmias. And in the old days, we actually used to give them to treat some dysrhythmias. So every dysrhythmia is, like, let's say your heart's going too fast. Well, you give them a drug that slows it down, and then all of a sudden it's too slow and you've got heart block. So now you give them a drug to speed up the heart, and the next thing you know, they're tachy again. So it's kind of like one of those, Goldilocks, not too much, not too little, just right. So you can actually use Dilantin or phenytoin to treat some dysrhythmias, but it causes others. So when you give it IV, you've got to pay attention to what the heart is doing. When you give it PO, it's usually not as much of a problem, but it is potential there. The big adverse effect in terms of common one that everyone is like, ew, is gingival hyperplasia. So what's gingivitis? So inflammation of the gums. So what's gingival hyperplasia? Yeah, that's overgrowth of the gum. So the gums can actually grow up into and over the teeth and engulf them completely in some cases. So you can prevent that to some degree with oral hygiene and flossing, but it's not always completely preventable. So it's one of those things where you need to educate patients about it, and they need to come back in, maybe be on a different drug if that's a really big problem. Does that make sense? All right. The next drug that we have is called carbamazepine. Mazepine. And that drug name or brand name is Tegretol. Now, Tegretol was a vast improvement over phenytoin, and you're going to see a decent number of people on that drug just because they were started with it after it became more popular. But it has a problem. And the problem is that it can cause bone marrow suppression, which can lead to potentially fatal aplastic anemia. Well, you can give it to kids, but you got to be more careful. And it's not as common with kids. Nowadays, we actually have newer drugs that you're more likely to be on than carbamazepine. Carbamazepine can also be used for bipolar disorder. And if you've got a drug that can cause aplastic anemia, what do you think we need to do to make sure they don't have it? Check the what? How could we know if they've got to check a CBC? So you're going to look at their blood counts. If they're starting to get low blood counts, what are you going to do? Take them off the drug, put them on a different drug. There is yet a newer drug that I forget how it's spelled, but it's like oxcarbazepine, which is the, don't quote me on that spelling. It actually might be carbamazepine, who knows. But it's basically carbamazepine that's been broken down into the active metabolite, and there's a much lower risk of the aplastic anemia with the ox version.
So that blocks sodium channels.
Say again?
So does that block sodium channels?
Yep, blocks sodium channels too. And then we've got a drug that some of you were talking about last class, lamotrigine or Lamictal. And that drug is also sodium channel blocker. And what? I know it's not on your drug list. I'm just talking about it. Yeah. And that particular drug is commonly used for bipolar as well. The main issue with the drug in terms of safety is it's a sulfa drug, and there's risk for Stevens-Johnson syndrome. All right. Next, we have drugs that inhibit potassium channels. And the main drug there is called ethosuximide. The brand name is Zerontin. And Zerontin works primarily on absence seizures. So you're going to see it quite common in kids. And which kind of kids? Kids who have absence seizures. Sometimes you guys are like, this is a really hard question. I don't think I know the answer. And I'm like asking you like the easiest question in the world. But it's so hard, I don't know. I'm just going to keep taking notes and hope he moves on. Yeah. The third mechanism is by potentiating GABA. Now, what do we know about GABA? It's an inhibitory neurotransmitter in the central nervous system. And we know at least 2 different types of drugs that affect GABA receptors, don't we? What are they? Benzodiazepines, okay, benzo-likes, but give me another drug class altogether. Starts with a B. Barbiturates. So barbiturates and benzodiazepines both work on GABA receptors, and they can both be used to stop, prevent seizures. Now, the main, we already talked about the 3 benzos, and that's going to be your diazepam, lorazepam, and clonazepam. And then for the barbiturates, the main one that's used is phenobarbital. What's in your notes? Oh, I'm sorry. Yeah, it is calcium. Not necessarily. Yeah. Say again? No, there's more drugs, but these are like the main 3 classifications, and then there's a few that kind of like go between. So let's talk about some drugs that span classes. So the first one is valproic acid, also known as Depakote. There's multiple brand names of that one. It's also called Depakine, and it's got a few other names, but valproic acid. Valproic acid works in all 3 ways. So it works by inhibiting sodium channels, calcium channels, and GABA. And as a result, it can be used for any seizure. Does that make sense? Oh, sounds like a wonder drug, doesn't it? It can also be used for bipolar as a mood stabilizer. Sounds like a pretty good drug. Well, the main problem with the drug is that valproic acid can cause acute liver failure. So you need to know signs and symptoms of acute liver failure. So abdominal pain, loss of appetite, nausea. What else do your notes say? Jaundice in more severe cases. So you need to be familiar with those signs of liver toxicity. Now, do we have any other toxicities that we need to be aware of from last class? Okay, lithium toxicity, and what else? Another toxicity, serotonin syndrome. I don't know, if I were a betting person, I think there might be a question or 2 on the test about those toxicities, and you might need to memorize and or recognize which one the patient is at risk for based on symptoms. That's what that, and anticholinergic effects too. Don't forget those. So mad as a hatter, hot as a hare, blind as a bat, all that stuff. Yeah, oh man, Dr. Heyman, I don't actually want to be a nurse. I just want to look like a nurse. Can we just wear scrubs? Yeah. All right, the next drug that we're going to talk about that kind of spans classes is levetiracetam. Levetiracetam. I can't spell it. Keppra.
So on our test, I
Mhm.
totally forgot about last year. We're gonna have both options, so we can study one that's easier for us.
Yeah.
We know both.
Yes, for the most part, I will have both.
Do we need to know Keppra even though it's 7?
Yes, you do need to know Keppra. So Keppra is really gotten a lot of it's gotten a lot of use lately because it is such a good drug in that it can be used for all seizure types. It's safe in kids. You don't need to monitor the levels. And you can also use it in bipolar disorder. So a lot of times Keppra is referred to as the wonder drug. But there's no particular mechanism that you need to know for that one. So Keppra is really commonly used nowadays. Because it's relatively new, and we usually start with the oldest drugs first. Yeah, don't ask me why. It's just what they do. They being the book, and the notes originally came out of the book. So, yeah, if you read the book, it's remarkably helpful. Shut up. Okay, let's move along. Okay, 2 other drugs that we need to know about are gabapentin, which has nothing to do with GABA. It's just called gabapentin. And the other one is topiramate. So the brand names for these 2 drugs are Neurontin and Topamax. So these are both typically used for partial seizures. They're not incredibly awesome at being anti-seizure medications. They're mostly used for other neurological disorders. So for example, neuropathic pain. If a patient has, let's say that they've had some sort of chronic pain, maybe as a result of herpes, so they've got postherpetic neuralgia, or they've had a surgery and they ended up with neuralgias after that. A lot of times they'll prescribe one of these 2 drugs for that. There's recently there's a push right now to classify gabapentin as a controlled substance. And the reason for that is there's so many people who can't get opioids that people are just desperate for anything. So they start taking gabapentin. And you can actually overdose on gabapentin and there's no treatment for it. So, oh my gosh, it's so dangerous. So every time the government tries to stop one problem, they cause another problem. And if you look way, way back in the 60s, American soldiers in Vietnam were getting high on marijuana. So they cracked down on people getting high on marijuana, and what they did is they forced them into heroin. And there's actually, I think it was a Army colonel or lieutenant colonel, he's got this memorandum where he's like, can we please just let them do the hash so that they can do hash instead of heroin? It's much easier to deal with marijuana high. It's like, so anyway, if you want to know why people do crystal meth and things like, overdosing on gabapentin, it's because, we can't let them be high on marijuana, so we crack down on marijuana. So then people turn to the alternative, which is going to be heroin. And then, we can't let them get high on heroin, so we crack down on heroin. And then they turn to cocaine. And so we got to crack down on cocaine. Oh, but look, let's do crack. So now you crack down on crack, pun intended, and then you end up with crystal meth, crack down on crystal meth, and you end up with bath salts. And then people eat people's faces off. And so every time you try and fix one problem, you create 5 other problems. So if you can't tell, I'm in favor of drug legalization. But won't people do more drugs? Well, they might, but they might do safer drugs, not the more dangerous drugs. And if they do want to do drugs because they're not afraid of going to jail if they get caught, they're more likely to ask for help. So that's...
So does it give you like high?
No, it doesn't make you high.
So why would you
Because you can get it legally, so you do what you can.
Feel good?
It doesn't cause euphoria.
That's weird.
Well, also remember that a lot of patients who are addicts started out treating pain. So they've got chronic pain, but they can't get enough opioid. So now they switch to it. They'll try whatever they can to reduce the pain. So, but anyway, so that's gabapentin. Topiramate is commonly used for patients who have migraines and also neuralgia pains. And it's sometimes known as the stupid pill. And the reason why is that it inhibits your ability to concentrate. So we had a student who was on this a number of years ago for migraines. And she's like, I don't know what to do because if I'm not on the drug, I have migraines to where I can't think. But when I'm on the drug, I can't concentrate at all. So I'm like trying to study and like there's a bird that flies by the window and I'm like, bird. What was I doing? So it's commonly known as the stupid pill because of that. It also suppresses appetite, so patients will sometimes try and get it for weight loss. Although I think there are much better alternatives for weight loss than topiramate. All right, so any questions about all of those lovely seizure drugs? There's one thing that I forgot that I wanted to mention before we move on, and that is ketogenic diet. And the main reason for that is that it's just such a big topic nowadays. We just need to address it. So ketogenic diet is a potential treatment for seizure disorder. It was first developed in the 1920s in its modern form. And basically what the patient wants to do is eat as little carbohydrate as possible. Now, some people can go into ketogenesis with as few as 100 carbohydrates. But for it to really be effective, it seems that you probably need to get to lower ketogenic levels than just beginning to get into ketosis. Typically, the smaller a person is, the lower the amount of carbs they can have, and typically women need to have fewer carbs than men to get into ketosis and stay in ketosis. So generally speaking, when a person is trying to get into ketosis, they recommend no more than 50 grams per day of carbohydrate, and for some people as low as 20 to 25 grams of carbohydrate per day. Now, drug treatment tends to be a little bit better. But no matter what the drug treatment is, about 35% of patients are still going to have seizures. We call those refractory seizures. They're seizures that the patient's having despite the drug treatment. So in those patients, it's highly recommended that we at least tell them about ketogenic diet and try it. The problem with ketogenic diet is that the compliance or adherence is very, very low. Probably even lower than for taking drugs. Because think about it, how many of you like food? And how many of you, when you see food that you want, it makes you hungry for it? And now all of a sudden, you can't ever have that again. Now, when most people say I'm doing ketogenic, they ask them like, well, how ketogenic are you really? You know, it turns out that they're ketogenic some of the time. Part of the time. But for it to really be effective for treating the epilepsy, it needs to be ketogenic all the time. And it's just very, very difficult for adults and adolescents to do that. It's easier for pediatrics, for kids to be compliant because kids typically don't make their own meals. So as long as their parents can stand it, then they can feed their kid that way. As far as adverse effects go, the main adverse effects of ketogenic diet are typically going to be weight loss, which hey, that's not so bad, unless you didn't have that much weight to begin with. And there's a couple mechanisms there, but the main one is it's just hard to eat enough calories when you're not eating any carbohydrates, because carbohydrates make foods taste better. The other issue that often happens in terms of that is that high amounts of fat, especially in the absence of carbohydrates, tends to have a little bit of a appetite suppressing effect. So patients just aren't as hungry. And if you've ever tried a ketogenic or an Atkins type diet, you're at the beginning of it, you're like, I can eat as much as I want and I still lose weight. And what really happens is you just haven't figured out that when you cut out the carbohydrates, you also cut out a whole bunch of other calories as well. So think about it for a moment. If you say any carb that you can think of, name a carb. Bread. Okay. How many people just eat bread by itself, or do you dip it in butter, spread it butter on it, dip it in oil with the spices, or maybe peanut butter and jelly? Yeah. So you typically are going to eat your bread carbs with some fat as well. Give me another one. Rice. What do you put on rice? Butter, cheese. Cheese
and broccoli.
Cheese and broccoli and rice. Sure, why not? I have a fantastic recipe for that for later. So think about some other ones. Potatoes. What do you put on a potato?
Garlic and butter.
Butter, sour cream, cheese,
Salt. Garlic.
salt. Deep fry it, aka French fries.
Ketchup.
Tons of garlic.
Okay, but garlic isn't got a lot of calories. That's why we're not focusing on the garlic. So when you cut out carbs, you're not only cutting out the carbohydrate calories, you're also cutting out all of those fat calories that went with it. And then you're replacing that with meat and salad with fruit. No fruit.
Berries.
Yeah.
No fruit.
Very little fruit if you're on ketogenic. Yeah. So it's really hard for people to eat enough fat without the carbohydrates, especially at the beginning of a ketogenic type diet. So they typically lose weight. The other thing that also happens is as you lose your glycogen, you also lose water. So that also contributes to the weight loss, and it can also contribute to hypovolemia. And then the last thing that can also happen that we need to think about is electrolyte loss, because you lose a bunch of water, you lose electrolytes with it, and you can also have the potential for hypoglycemia, especially if your patient actually does have a seizure. So remember that patients who are in the post-ictal state are often hypoglycemic, except now their body doesn't have a reserve of glucose and glycogen to draw from, so the chances of hypoglycemia are even higher. I've got a podcast you guys can listen to. It's a guy, he's a chef, and he does a cooking podcast, but he's got a son who was diagnosed with epilepsy. And so it talks about, his aura, and then talks about his seizures and what happened. And so they've tried all of these things. They tried a ketogenic diet. It didn't work for him, and the kid was miserable the whole time. So they tried like a vegan diet, and that didn't work. They tried all different types of diets to see if it would work, and none of them have worked for this child's epilepsy. And he's a professional chef, so he's like, I know exactly how you make this food taste good. He's like, but you're just giving up so much that most people just can't handle that diet long term. So if it works for your epilepsy and you enjoy it and you can stick with it, then it can be an option, but just the failure rate is rather high, even if it does work for the treatment of that person's epilepsy. So the most important thing is it should be considered an option, but the specific plan needs to be tailored to that individual. If you have a relatively large male who's quite active, they're going to be able to eat more carbohydrates and still be in ketosis than you have a relatively small female who's sedentary. So I've given two extremes there, but everyone comes in different degrees between those kind of two extremes. Does that make sense? Okay, so on that note, we're going to move along. All right. Next, I believe we have stroke. Is that correct? Brain trauma. Okay, brain trauma. This is one of my least favorite subjects. You want to know why? No good at it. I'm not good at lots of things. I just fool you because I'm better at it than you are. It's easy to look good when you know nothing and I know a little bit. So that's just why you think I'm smart. I'm not actually smart. So brain trauma. The nature of a brain trauma and the symptoms that happen depend on what part of the brain is damaged. So if the part of the brain that's damaged is one little part, the symptoms are going to depend on what part was damaged. Does that make sense? So we call those focal symptoms. If the entire brain is damaged, then we're going to get generalized symptoms, just very similar to the way that seizures work. Now, when you get hit, you got to see that, huh? So when you get hit in the head, your brain is actually floating inside your skull. So when you get hit hard enough on the head, the bone is actually going to hit into the brain. Then the brain is going to bounce off and hit the back side of the skull. So you're actually going to get hit on one side and then get hit on the other side inside your brain. Does that make sense? So that's known as the coup and the contra coup. Coup means blow in French. So it's the blow and the counter blow. So you're going to get hit on both sides. So you can have symptoms potentially from both sides of the brain because you're getting hit in two different places. Does that make sense? Okay. When you damage the brain, we're going to call that a concussion. And concussions are graded on a system from 1 to 5. So grades 1 through 3 are considered mild. And a patient does not lose consciousness in 1 through 3. Once they get to 4, at this point, this is called a true concussion, and a person loses consciousness. So in a stage 1 or a grade 1 concussion, the person does not lose consciousness, and they might be slightly disoriented, and they could have what's called moment amnesia. What does that mean? Like, what just happened? So they don't know what's happening in that moment. They forgot that moment. So as you get more severe, you go from the moment to, I think it's about 10 minutes of loss of memory. And then in stage 3, what is it? About 15-ish minutes. And then once you get to a true concussion or classic concussion, how many minutes do you typically lose there? You can lose up to 6 hours. So less than 6 hours. So up to about 6 hours of memory loss. And what's the key? What's the dividing line between these mild ones and the classic or grade 4? Loss of consciousness. You don't lose consciousness in 1 through 3. I don't know. What's it say in your notes? There isn't a 5. Well, there might be a 5, but not on our grading.
You said 1 to 5.
I know.
So 4 and 5 is up to 6.
Yeah.
Okay.
Sure. Whatever. I read the book.
Is there not a 5?
It's not a 5.
It's 1 to 4.
Yeah, 1 to 4.
Oh my goodness.
There might be a 5, just not in the notes. How's that? Like I said, I'm not very good at this stuff. The important thing is, when you have traumatic brain injury, you may also have bleeding inside the brain. And the bleeding can be either arterial or venous. Now, which of those do you think is going to be worse? Arterial. Why? Pressure? There's more pressure. It's under pressure. Bum, 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 bum. Yeah, so it's like a Queen song. So because it's under pressure, it's going to be putting more pressure inside the brain, which is going to cause more injury to the brain. So, and it's going to happen much, much quicker. Now, a venous bleed will take usually several days before it really builds up to having big symptoms, at least 24 hours, whereas an arterial bleed can happen within a couple hours. Now, how many of you have ever heard this story? Don't ever let someone who's had a concussion fall asleep. It's not true. You can let them sleep. The key is you want to make sure that they're sleeping and not unconscious. How do you tell the difference? What? Try waking them up. If you can wake them up, then they're cool. If you can't arouse them, then you need to go seek medical attention. Does that make sense? So it's not that you can't allow them to sleep. It's that you need to make sure that they're not unconscious. And how do you do that? Try and wake them up. So do you remember back to levels of consciousness you learned in health assessment? So it's like spontaneously opening your eyes with voice commands, opening your eyes with physical and voice. Annie, are you okay? You learned that in CPR, right? Yeah. And then beyond that is to have pain stimulation. So that's what you're looking at in terms of can you arouse them? How much stimulation does it take? When it comes to spinal cord trauma in particular, it's been controversial both directions, but we're leaning towards doing it now, which is you want to give the patient steroids. And the idea is that by giving them steroids very, very early on, you inhibit the inflammatory response, which is going to be accompanied by edema, and the edema will cause additional damage to the spinal cord and brain. So when a patient has traumatic head injury or spinal cord injury, you want to administer steroids very early on. All right, any questions about traumatic brain injury? All right, next, now we have stroke, right? Cerebrovascular disease? Yes, that's strokes. All right, so cerebrovascular disease. What does cerebro mean? Of the brain. What's vascular? Of the blood vessels. So this is going to be either clotting or bleeding too much. Well, bleeding at all inside the brain. They're both going to end up causing the same problem, which is called a stroke. Now, in the old days, we called them strokes. And we called heart attacks. But then we got really cool and we stopped calling them heart attacks and started calling them myocardial infarctions. And so the people who took care of stroke victims were like jealous. How come we can't have a cool name like myocardial infarction? So they came up with the name cerebrovascular accident, or CVA. And we used that for a little while, but then we're like, well, that's stupid. Let's call them strokes. So then we went back to stroke. And then they're like, well, it's kind of like a brain attack. It's like a heart attack, but in your brain. It's a brain attack. But that never really caught on. So for the most part, I'm going to call it stroke. But if you might hear CVA, you might hear cerebrovascular accident, you might hear brain attack. Just depends on, kind of like when that person went to school and what was popular at the time. That's probably what they're going to still call it nowadays. So there's two distinct forms of cerebrovascular disease. The first one is ischemic. What does that mean? Not enough blood flow. Now, the main problem in ischemic is usually either a clot that is broken free. And what do we call a clot that's broken free? An embolism. So, if a person has surgery and they're not moving around as much as they used to, what are they at risk for? DVTs, deep venous thrombosis. Now, if that deep vein thrombosis breaks off, what's going to happen to it? It's going to travel up to the heart. Which side of the heart? The right side of the heart. And then it's going to go into the lungs and cause a pulmonary embolism. But some patients have a little hole in the septum of their heart, patent foramen ovale, PFO. If they've got that, it's possible for that clot to cross through to the other side, now go up to the brain and cause a stroke. That would be an embolism. What's your heart supposed to do? Show me with your hands. So here's your atria, here's your ventricles. What's supposed to happen? Right? Well, what happens if your atria are just doing this? Atrial fibrillation. So the blood in the atria, is it getting squeezed down into the ventricles very effectively? No. So some of that blood is just hanging out up in there, right? What does blood that hangs out do? It tends to clot. And those clots could do what? They could break loose. So atrial fibrillation is a potential source of embolism in the brain. Now, if a person has a myocardial infarction, what does myocardial infarction mean? Well, I mean, it is a heart attack, but what does it mean, literally? Heart muscle cell death. Now, not all of the heart muscle, but some of the heart muscle. Now, does dead heart muscle contract very well? I'm going to go with no. So the portion of the heart that's dead, that part of the muscle wall is not going to be as contractile, right? So the blood right up against that is not going to be pushed away as easily. So it can pool right there, and wherever you have that kind of like dead spot, you can end up having a clot. So there's ventricular clots that occur from myocardial infarction. And that, when they break off, can lead to strokes, embolic strokes. So ischemic strokes can be embolic, and you also have buildup of atherosclerosis in the carotid arteries. How could you tell at all? Is there anything we can do? Okay, you can auscultate for bruits. Those are going to be fairly late signs. You can also do ultrasounds of the carotid arteries. But if the atherosclerosis in there breaks off, where is it going? Straight up to the brain. So several different sources of embolic strokes. The other thing that you can have in ischemic strokes is you can just have what's called a complicated lesion. So in this case, it's exactly the same as what happens in the heart for a heart attack. You've got atherosclerosis building up inside a blood vessel, and then it breaks open and allows the inners to goo out, and that's going to cause a clot. So when we talk about ischemic strokes or thrombotic strokes, so within ischemic, we've got embolic and we've got thrombotic. So what causes a thrombotic stroke? An complicated atherosclerotic lesion. What do I mean by complicated? It broke open. Okay, so what kind of lesion is it? It's an atherosclerotic plaque that breaks open. When it breaks open, what do we call it? Complicated. A complicated lesion. So, embolic strokes occur from thrombi somewhere else in the body that floats up. Thrombotic strokes occur in the brain from a atherosclerotic plaque that broke open. Okay. So let's just get rid of all that and say ischemic strokes are either embolic or thrombotic. Now, either way, you're going to treat them the same. How are you going to treat it? There's a popular movie from the 80s called Ghostbusters. Only we're not trying to bust ghosts here. What are we trying to bust? Clots. Clot buster. Okay, so you can give thrombolytics or just in general antiplatelet and anticoagulant. Now, ideally, you would give a thrombolytic, and what time frame would you give that thrombolytic in? Within 2 hours. It's going to be most effective within 2 hours, and if possible, you'd like for it to be within 20 minutes. But there's a problem. And what is that problem? If the patient is not having an ischemic stroke, if they're having a hemorrhagic stroke, what is a hemorrhagic stroke? The patient is bleeding in their brain, and you give a thrombolytic. What's going to happen to that poor little patient? They're going to die, and it'll be your fault, you and the doctor. So we don't just treat strokes by symptoms. What do we have to do before we can give them a thrombolytic? What kind of scan? CT or MRI, MRA. So magnetic resonance angiogram is probably the most common at the moment. But you need to do some sort of imaging of the brain arteries to make sure that they're not having a hemorrhagic stroke. If they're having a hemorrhagic stroke, you do something different. If they're having an ischemic stroke, ideally a thrombolytic, but time limited, and you can also give antiplatelets, anticoagulants. The earlier you reverse the damage, the fewer sequela there will be. What's a sequela? Well, technically, it's different than a complication. Right. So it's signs and symptoms that occur as a result of the disease. So because you're destroying brain tissue, you're going to end up with certain symptoms at the end. Those are sequela. So some sequela, very common sequela would be paresthesias, paralysis or partial paralysis, one-sided weakness, hemiparesis, visual changes, and communication changes. What's it called when you can't talk? Are you guys pretending to have this problem? You all had strokes and now you have expressive aphasia? Okay. So aphasia is an inability to communicate or a reduced ability to communicate. So expressive aphasia is an inability to express what you want to say, typically trouble speaking. Sometimes patients will not be able to talk, but they can still write. And that's just how much of the brain has been damaged. Now, what's it called when you can't understand what's being told to you? What's it called when you can't understand what's being told to you? That's receptive aphasia. And again, sometimes patients won't be able to understand words that are spoken, but they might be able to still read. So you can have weird things like that. So those are all sequela. Now, imagine for a moment that because a person has a sequela of dysphagia, they can't swallow very well, they end up aspirating and getting pneumonia. What would the pneumonia be called? A complication. So there's a subtle distinction between sequela and complication, and some people don't care about the distinction and use the two words interchangeably, but there is a difference. So if you're talking to someone who cares, you know what the difference is. If not, well, they're all complications. So the sooner you can get the treatment, the fewer sequela there'll be, and the better we'll be able to rehab that patient. But we've got to make sure it's not hemorrhagic first. Now, the treatment for hemorrhagic stroke can vary. There are some medications that can increase clotting. We're not going to go over any of them. And then there's also surgical procedures that can be done as well. Again, we're not going to go over that in this class. By the way, I do expect that you will know all of the thrombolytics, anticoagulants, antiplatelet drugs from Pathopharm 1, because, you can use those here. So that means you need to know how to use heparin, PTT values. You need to know warfarin, INR. You need to know that you would never use INR, or you would never use warfarin to treat a patient who's got the stroke right now, but you might send them home on warfarin. Heparin is right now, yes. I know, right? It's like I just killed the whole party. All right. Anyway, so stroke is the number one, well, actually it's not the number one anymore. It used to be the number one cause of disability in the United States. Now it's just a leading cause of disability. What's the number one cause of disability among old people nowadays? No. Loss of muscle mass from sarcopenia. So just muscle loss. But when patients have a stroke and they've got hemiparesis, a lot of times they will let that be a catalyst to allow their muscles to go down. So if a patient's got hemiparesis, they've got one-sided weakness, what should you do as a nurse? Okay, do you build that side up, or do you make it so that they can use their other hand for everything? Is it better to teach them how to compensate with their strong hand, or is it better to teach them, try and get them to use their weak hand more? You actually want to use their weak hand more, because if they don't use it, they'll never regain it. Does that make sense? So you want to put things, like let's say that the right side is weak, you want to put everything where they have to use their right hand to get it. So if you put something here, they're going to go, oh, left hand, good, ha ha, sucker. So you put it over here. Now it's harder for them to get it with their left hand. They've got to use the right hand. Does that make sense? So it's going to suck for them, but you're not doing them any favors by coddling them. Does that make sense? It's just like, from the moment your kid can tie their shoes, you should never tie their shoes again for them. Because every time you tie their shoes for them, what are you doing? You're sending them a message. I'm better at this than you. I'm faster at this than you. You suck, so just have me do it all the time. And then they'll never learn how to do it. So the same thing applies with patients who have had strokes. All right, any questions about stroke? What's next on our list? Meningitis? All right, meningitis. So the meninges is the outer lining of the brain and spinal cord, and it is susceptible to becoming infected. And it can become infected with a number of different things. Viruses are the most common, and they are self-limiting. What does the word self-limiting mean? I thought you answered the question under your breath. So what does self-limiting mean? They get better on their own. So you don't necessarily have to treat them. It's just going to get better. So viral meningitis is not particularly concerning, but bacterial meningitis is concerning for two reasons. One, it is potentially life-threatening. And if the patient doesn't die, they may have permanent brain damage. So for the most common causes of meningitis, meningococcal infection, there is a vaccine that you can use. And if you live in the dorms here at PBA and most places in the country, you're expected to get a meningococcal vaccine. And then beyond that, we want to treat them with antibiotics. What kind of antibiotics would we use? Ones that can cross the blood-brain barrier. Like, don't ask me that. Like maybe third or fourth generation cephalosporins, as an example. Now, as far as treatment, as far as symptoms go, patients will typically have uncontrolled nausea and vomiting, severe headaches, and nuchal rigidity. So nuchal in this case means of the neck. So if you ever read in a doctor's note, neck supple, what they're really saying in a subtle way is that this patient doesn't have nuchal rigidity. But this is my opinion, I think that most doctors who write neck supple didn't actually test to see if the neck was supple. They just, the patient didn't complain about it, must be supple. So there's actually a specific way you're supposed to test for nuchal rigidity where you have the patient relax lying down and you pull their head up. And most doctors don't actually test for that. They just go, neck supple. Now, not every doctor does that, but I'm just saying I've seen it a lot of times written by doctors who didn't actually test for it. So take it with a grain of salt, but that's the implication. If a patient is suspected of having meningitis, what do we want to do for that patient as a diagnostic test? Lumbar puncture. So we're going to stick a needle into their spine and pull out some of the fluid, and then we're going to test that to see if there are bacteria present. In the old days, sometimes that was referred to as a spinal tap. But for the most part, you're not going to hear people say spinal tap except for lay people. People in the healthcare field almost always say lumbar puncture or LP. Does that make sense? All right. Any questions about meningitis? Oh, there'll be a bonus question on your test based on a short story by Horacio Quiroga. His stories are about growing up in Paraguay or living in Paraguay. And the particular one you're going to talk about is called if you want to read it, it's called the decapitated chicken. Oh no! Well, I'm sure you can Google it and find it. But anyway, you can even read it in Spanish if you want to. It's about what happens when we don't have modern medicine and how just incredibly terrifying meningitis could be. Because you've got a normal kid one day, and then the next day they get an infection, and they never recover. And so your wonderful, perfect little kid is now, what's the right word to say? Well, in the book, he uses the word idiot. By the way, did you know that the word retarded means slow? And it was originally a euphemism for the much more harsh word idiot. They're not an idiot, they're just a little slow. They're retarded. But we live in such a crazy mixed up world that the euphemism is now more offensive than the actual insult. Because if you call someone an idiot, I mean, that's rude, but you're not going to get Special Olympic people calling you out on social media. But he calls someone retarded and is like, oh no, the world has ended. Mix up tipsy-topsy world, I tell you. But anyway, that's the world we live in nowadays. The next one is encephalitis. So meninges, remember meningococcal is the lining around the brain. Encephalitis is an infection of the actual brain tissue. So encephalitis. So this can be caused by a number of viral diseases, and it can also be caused by toxins as well. But here in South Florida, the big danger is mosquito-borne diseases like West Nile or Eastern equine encephalitis. Those are caused by mosquitoes, and they do live here in South Florida, and you can get them. They're fairly rare, but it can happen. If you go overseas to exotic places, then you're a higher risk for those encephalitises there as well. That's pretty much it for that. All right, what do we have next? Huntington's disease? Multiple sclerosis. Okay, multiple sclerosis. What does the word sclerosis mean? Sclerosis means hardening. And the disease is characterized by loss of myelin sheath in the central nervous system. So the defining characteristics there are central, patchy. What does patchy mean? Patchy. Is that like an Apache engine? You don't even know what that means, do you? You don't know what Apaches are? Oh, they're helicopters, of course. But no, an Apache is an Indian tribe. You guys don't watch any. Okay, well, you didn't say so, so you didn't. That means you didn't know. So, cowboys and Indians, the Apache tribe. Anyway, okay, bygones. It's like an entire generation anyway. Okay, it was lost. So, back to our story. That is not what it means. What does patchy mean? Patches. What's a patch of something? Yeah. So, a patchy pattern means that it occurs in spots. There's no like real pattern to it. It's no organization. It's just little bits and pieces all over the place. So, the demyelinization is central nervous system, and it's patchy. There's no organization to it. And it also tends to be intermittent. What does that mean? Comes and goes. So it's characterized by spontaneous periods of remission where a patient gets completely better for a while. Or maybe not completely better, but significantly better. We're not sure the exact cause of it, but it seems to be related to autoimmune disorder. It's most common in young women, but it can occur in men as well, and it can also occur older in life. But, that 20 to 30-year-old female is kind of like the typical person who gets it. Because it's intermittent and because it's patchy, it's very difficult to know whether your drugs are working or whether it's just spontaneous remission. So when you look at people who have this, you'll have one person who swears by a particular diet. It was the diet that did it, and that's why I'm better. And then you find someone else who's like, I tried that exact same thing and it didn't work at all. Was it that, well, the diet worked for some people and not others? Or was it that one person just happened to be in remission? And no one really knows. We're not going to go over specific drugs for it today, but just know that there are drugs that can help. But again, it's hard to know how effective they are versus was it just remission. Over time, it's going to get worse and worse. So it's called progressive. So when they have a decrease in function and then they come back up, but they're never quite regaining their former level. So you'll notice that over time, they're getting worse. Does that make sense? So that's what we mean by progressive. And it can impact a number of things from perception to motor function, and then eventually can also impair cognitive function as well. So in the later stages, patients will have trouble thinking and remembering things. Any questions about multiple sclerosis? All right, we're going to contrast that with another neurological disorder that's characterized by demyelinization, and that is called Guillain-Barré syndrome. Now, Guillain-Barré syndrome might not be next in the notes, but I'm putting it next. How's that? Is it next? Oh, man, I'm good, but I'm spelling it wrong. Guillain-Barré. Okay. He's French. Kind of. And it's not beret like the hat. That's spelled differently. It's like Mr. Beret. So Guillain-Barré syndrome is characterized by demyelinization, but instead of the central nervous system, it is peripheral nervous system. And instead of being patchy, it's ascending. What does that mean? Yeah, so it starts at your extremities and then works its way upwards towards the middle of your body. It is potentially life-threatening because if it affects your respiratory muscles, it can cause respiratory failure and you die from respiratory failure. So the number one most important thing, it's also typically self-limited. What does that mean? You get better on your own if you don't die. So there's no real effective treatment for it. There's no real treatment for it. Well, never mind. There are some treatments you can use. But you don't necessarily need to treat the patient because if you keep them alive, they'll get better on their own eventually. Now, that eventually can be relatively quick or it can take a very, very long time. So sometimes it can take 2 years or more for a person to get back to more or less normal. And some patients will never quite be normal again. As far as what causes it, we're not 100% sure, but it seems to be some sort of autoimmune activation where your immune system is kind of attacking the body. And precipitating events can be anything from a surgery to an immunization to a bacterial or a viral illness. So any of those things can be potential precipitating events. Surgery, bacterial infection, viral infection, and immunizations. Campylobacter. Yeah, the Campylobacter is in particular, seems to be one of the major ones in terms of causing it. But it's a very weird, quite rare disease. But what do quite rare disease people do? No. Eventually, yes, but not immediately necessarily. What do? They go to healthcare facilities. So in the hospital, one of the weird things that happens as a nurse is that you see all of these very rare things because they come to the hospital for care. So to you, it's very common. We see that all the time. But in reality, it's like 1 out of 10,000 people has it. But what do those 1 out of 10,000 people do? Go to the hospital. So one of the things you got to be careful about as a nurse is your perspective can be completely skewed on how often something actually occurs. And the bigger the hospital setting you're in, like if you're in like a university or research hospital, you see the weirdest cases. So that really skews your perspective. So like if you work at St. Mary's in the labor and delivery, you think that every woman is a complicated delivery. Whereas if you live like in a little, if you work at a little regional hospital, almost all of the births are normal. So you're like, well, lots of births are normal, whereas every birth is abnormal. And that's just based on the location of where you work. All right, we're not quite done. I think we have Huntington's disease and ALS to go, right? Okay, we should be able to do that in 10 minutes and be done by 4. So let's go. Huntington's disease. Now, we haven't covered genetics yet, but we're going to do genetics next class, so I don't feel bad talking about this particular thing. Huntington's disease is an autosomal dominant disorder. So what that means is, every one of our genes is a pair. Sorry, every one of our chromosomes is a pair, right? You get one from mom, you get one from dad. So when your mom and your dad, if one of them is in their pair, one is positive and one is negative, so let's say this is your dad, this is your mom has no choice but to give you a negative gene, right? So you will never be able to inherit Huntington's disease from your mom. Now, from your dad, you got one of two choices, right? Either you're going to get it or you're not. If you get the negative, you're not. If you get the positive, you will get Huntington's disease at some point in your life. Does that make sense? Now, the disease is not just yes, no. The disease is caused by overproduction of a particular protein in your brain. And when you overproduce that protein, it poisons your brain. So when you inherit the chromosome from your parent who's got the gene themselves, you could be inheriting a very mild form where you only have a little bit of that toxic protein, or you could be inheriting a very dangerous form of it where you're producing enormous amounts of it. And then, for whatever reason, some people have the gene that is turned on just a little bit versus some people it's turned on a lot. So there's a wide array of variability in the expression of the disease. But if you have the gene, you're going to have the disease eventually. Does that make sense? It makes toxic proteins. So remember, the whole purpose of a gene is to make a protein. And in this case, it's a protein that is a poison. So it's poisoning your brain. Now, most people do not get Huntington's disease until they're in their late middle age. So late 40s, early 50s is fairly common. But if you've got a more severe form of it, you could have full-blown Huntington's disease in your mid-20s. I've seen a patient who was 27 years old who had Huntington's disease so far, so advanced that you couldn't tell if there was a person in there to talk to or not. So what happens as a result of this disease is that you begin to have uncontrollable movements they call chorea. So it's Huntington's chorea. Now, what word comes from chorea? That's a dance term. Choreography. So chorea means dance. And so choreography is, making a dance move, whatever. Dance routine. So in the Huntington's disease, they begin to be able to kind of writhe uncontrollably, and that's called Huntington's chorea. It's kind of like a painful looking movement, and again, they're not in control of it. And as it progresses, eventually they'll lose complete control of their body, and they won't be able to move voluntarily anymore. They'll just have those Huntington's chorea movements. So you're not sure, is there a person to be able to talk to or not inside of their body? At the same time, they're also beginning to lose cognitive function as well. Now, this is one of those things where you can get genetic testing for it, but do you want to? Now, I know what you're all thinking. I would want to know if I have that gene, but do you really? Because what happens if you're 24 and you discover you have the gene? You might get Huntington's disease anywhere from 25 through 65. You know what happens? People who find out they have the gene a lot of times, they commit suicide. Now, you might have been able to live for the next 30 years disease-free, but you never knew that because you decided to commit suicide because it was too hard to know. It's like when students say, Dr. Heyman, please let me know if I pass the test. I need to know. The stress of not knowing is worse than knowing. No, knowing you failed is worse than thinking you may have failed. Every time. You only think it's not as bad because you happen to pass it. Just so happened, yeah.
So wouldn't you know if your parents would have it?
Well, you would know that there's a risk for you to have it, but there's a 50% chance you don't have it.
Okay.
But once you get genetically tested and you know you've got it, now you're looking at, we all know we're going to die someday, but we don't all know that we're going to lose control of our bodies, and it could happen within the next 5 years. I do not recall. But anyway, that is Huntington's disease. There is currently no cure for it. But again, with gene therapies, we're working on ways to be able to turn that gene off so that you don't actually get the disease in the future. Or if you do get it, it'll be more mild. The last one is acute lateral sclerosis, also known as ALS. And with very rare diseases, if a famous person gets the disease, you know what we do? We name the disease after them. So unfortunately, you guys don't have much sense of history, so you might not know who Lou Gehrig was, but at the time, he was a very famous baseball player. And he got ALS, so they named the disease Lou Gehrig's disease in an attempt to raise awareness for it. Nowadays, you may remember about 5 or 10 years ago, yeah, it was like I think it was like around 2011, there was the ALS Ice Bucket Challenge. Now, the original challenge was supposed to be either you donated $100 to research, or because you're a wuss and you didn't have the guts to do that, you pour an ice bucket over your head, bucket of ice over your head. But somehow that got changed in social media to, hey, I'm calling all my friends out. You got to do the ice bucket challenge too. You put ice over your head so we can raise awareness. You know, the whole point was supposed to be let's raise money. And if you didn't want to give money, the punishment was you got ice over your head. But, you know, I guess it's the telephone game, and things get changed around. So what happens in ALS is a person loses the ability to move. And it usually is ascending. It starts with fine motor skills in the fingers, and then it travels upwards until eventually paralyzes the muscles for breathing, and the patient dies at that point. So a lot of times the reason patients will get diagnosed is because they start tripping and or they feel like they're more clumsy than usual. From the time a person is diagnosed till the time they die is typically about 4 years. It could be less or it could be more. It's a disease where, for the most part, the person is still completely with it, although there is some cognitive decline toward the end. But for the most part, their normal brain function in terms of cognitive function, but their body no longer obeys them. So it's kind of like they're locked in a prison of the body they can no longer control at all. There is a movie with Charlize Theron where she's like the first, she's in a mine or factory, and like the union doesn't want her. And her best friend in that movie dies of Lou Gehrig's disease of ALS. So if you want to see kind of what it looks like, at least from an actor's perspective, you can go watch that movie. Can't remember the name, sorry. All right, any questions about ALS? No drugs for ALS that you need to learn. All right, see you guys next week.